Today we are going to discuss one of the specific circulation in cardiovascular system. We are going to discuss pulmonary circulation. We have many topics you should know in this important title. First of all, you should know functional characteristics of pulmonary circulation. Pulmonary circulation is characterized by high distensibility. So it is called distensible circulation, and it can accommodate large volume of blood. So if it is distensible, so it is characterized by low pressure system. And as you know previously from Ohm's law, if your resistance is low, so this means that your pressure is also going to be low. It's very important, and we are going today in this video to prove what we are saying. Pressure in pulmonary circulation is definitely low if you compare it with systemic circulation. You know that in aorta, average systolic is 120 millimeter mercury, while average diastolic is 80 millimeter mercury. But regarding pulmonary circulation, your average systolic is going to be 25 millimeter mercury, and this is very important to know, while diastolic equal 10 millimeter mercury. So this will prove that it is a low pressure system. I want you to know that there is different values regarding the pressure of pulmonary circulation. As for example, if you are asking me about the pulmonary capillaries, you will have pulmonary capillary average pressure equals 7 millimeter mercury. This is the pulmonary artery and arteriole, while this circle is pulmonary capillaries and the pulmonary veins. This will be 125 millimeter mercury. It's very important to know. And there is mean pulmonary pressure equal 15 millimeter mercury. It's very important. And your question now to me, I imagine, what's the importance to understand and know that the pulmonary pressure is 25/10? Regarding clinical point of view, if the pulmonary arterial pressure exceeds 35 millimeter mercury, you are going to have pulmonary hypertension. It's very important to know. And pulmonary capillary pressure equals 7. This is responsible for pushing the fluid outward from the pulmonary capillary through these pores. And you know, pushing fluid outside pulmonary capillaries to the pulmonary tissues outside, this is a force which is called filtration. It's very important. You are making the filtering force push fluid outside. At the end of this video, you will know that there are different forces which can push the fluid from pulmonary capillaries to pulmonary tissues. Not only pulmonary capillary pressure, which equals 7 millimeter mercury. So if you return back to the functional characteristics, it is distensible with low pressure system. Second, and the second information will be continuation with the same meaning. It has high compliance. Yes, and you know compliance before regarding the respiratory videos. Compliance means distensibility or means capacitance. It's very important to know. Number 3, it is a high flow circulation, and this is very important. The pulmonary blood flow equals cardiac output, and this is one of the factors which affecting pulmonary arterial pressure. It's very important to know. You know that cardiac output equal 5 or 5.5 liter during rest. All of you know that pulmonary artery receives the blood from the right ventricle. Number 4, which is very important, venous return at the left atrium. You know that the lung oxygenate the blood coming from this arch, which is called pulmonary artery, and then distribute the blood to 4 pulmonary veins. This blue arches into the left atrium. So venous return, which is abbreviated by VR, at the left atrium is 1 to 2% greater than right ventricular output. Also, blood flow in pulmonary capillaries is so rapid. If you return back to respiratory videos, you will know this information, that the red blood cells take about 0.75 second to move from across the pulmonary capillaries, while this time will be less to 0.3 second during exercise. So number 5, you will know that you will have rapid flow, and this is very important to understand. And according to the functional characteristics, you also have the pulmonary capillary surface area and permeability are great. You know previously that not all pulmonary capillaries are open. Some are open during rest to help in exchange, and while others are not. All of you know this drawing. This is the alveoli. Alveoli in the lung, and you have 300 million alveoli. This alveoli will make exchange with pulmonary capillary. Pulmonary capillary is a black cup, or like it is a black like this. This black part contains carbon dioxide. You have exchange. Oxygen move from alveoli to pulmonary capillaries, which I put my finger on it, while carbon dioxide moves in the opposite direction from pulmonary capillaries to the alveoli. This permeability will be higher during exercise. Another important information that regional blood flow is affected by gravity. And this information, effect of gravity, I am going to discuss now in the second title, regulation of pulmonary flow. But all of you know that blood accumulates in the base of the lung by the effect of gravity. Support this triangle is the lung, so you will have here at the base high flow, and at the apex you will have less flow. And this information is so important because tuberculosis, which is one of the bacterial infection, will attack the lung at the apex, because less flow means less immunity. You don't have enough white blood cells at the apex, so you are going to be attacked at your weak point. And if you remember before, we said ventilation perfusion ratio. Ventilation perfusion ratio is higher at the base while it's low at the apex, and all details are discussed before. Also, you have important information. Alveoli are kept dry or almost dry, which means this information that you don't have excess fluid in the center of the alveoli. You have only water film lined the wall of the alveoli, represented by this black dashes, which means that CO2 is high water soluble than oxygen 24 times. It can move from pulmonary capillaries across the water film lining the alveoli to the center. But this alveoli is not full with water. Suppose this is the alveoli. I don't tell you that all of these are filled with water. No, this is called pulmonary edema, and this is prevented by specific factors we are going to discuss at the end of this video. Another important functional characteristics, which is number 8, regarding pulmonary circulation, it is a specific circulation. It's a reaction to hypoxia. Suppose one bronchus is obstructed, don't have enough oxygen. So what about the pulmonary capillaries, which is going to give it carbon dioxide? You will say, doctor, CO2 should also be low, because if you have exchange between O2 over CO2 carbon dioxide, there it should be equal matching. What do you mean by this? I mean by this that pulmonary capillaries, which is this, I put my finger here, pulmonary capillary, here is pulmonary capillary, receives the blood from pulmonary artery. Pulmonary artery is the only artery carrying deoxygenated blood. Yes, so it brings carbon dioxide. If oxygen level at the numerator is low, by obliteration of the bronchus, you need carbon dioxide at the denominator also to be low. So carbon dioxide comes from pulmonary artery. So pulmonary artery should be constricted. I should decrease the flow of carbon dioxide to pulmonary capillaries. Why? To make matching. We want to make this matching. So the specific information about this knowledge, new knowledge, that hypoxia here will make vasoconstriction. Yes, vasoconstriction to pulmonary artery. You are going to obstruct this to make it constricted or narrower, not totally obstructed. And this is different from other tissues. Other systemic capillaries, we say that hypoxia make vasodilatation. So this is one of the functional characteristics. And I want you to imagine the wisdom of God to create this. What is the importance to have high carbon dioxide to exchange with low oxygen level? It will be a mess. So you should equalize numerator with denominator. This is very important. Regarding the regulation of the pulmonary flow, first of all, we have two information. Overall regulation of pulmonary flow. It is a passive process. Yes, it is a passive. During exercise, you know that cardiac output is going to increase markedly. So right ventricle will pump large volume of blood to pulmonary artery. Yes, so in this information, pulmonary vessels are going to dilate. So if pulmonary vessels dilate, resistance will drop and pulmonary flow will increase. All of you know that flow equal delta P over R according to Ohm's law. So if resistance decreases, by this flow is going to increase. This is very important. Number two, in the classification of regulation of the flow, you are going to have regional flow, which means that pulmonary flow is going to be different according to two factors. Number one is the oxygen tension, and you know this by the effect of hypoxia, as we said before, will make local vasoconstriction. And yes, this is local. It is specific for pulmonary circulation, not systemic circulation. And we are going to shift the carbon dioxide high level away from the under-ventilated alveoli to make matching. Number two, in the regional, we have the effect of gravity. It's very important. In the upright position, the apex of the lung are above the heart level, while the base is below the heart level. By the effect of gravity, there is a pressure created, a gradient created in the pulmonary arterial pressure, 23 millimeter mercury. At the lung apex, you will have pulmonary pressure 15 millimeter mercury less than that of the heart level, while at the lung base it becomes 8 millimeter mercury greater than the heart level. This is very important. At the apex, it is going to be low. At the base, is going to be higher. And such a pressure difference will make marked effect on regional pulmonary blood flow. It causes intermittent pulmonary flow at the lung apex only during systole, but continuous pulmonary flow at the lung base during both systole and diastole. Continuous pulmonary blood flow at the lung base will lead to increase pulmonary flow downwards, as if it is a waterfall effect. Waterfall like that of Niagara in Canada. So I want you to imagine that regional blood flow will be variable according to two factors: oxygen tension and effect of gravity. What about factors affecting pulmonary arterial pressure? I said pulmonary arterial pressure systole 25 millimeter mercury, while diastole is 10 millimeter mercury, and we have different numerical values regarding pressure: pulmonary artery, pulmonary capillary 7, pulmonary veins 1 to 5 millimeter mercury. So regarding resistance, you have 5 factors. Number 1 is nervous factors. Nervous, you imagine what I am going to say. Autonomic. You know that sympathetic cause vasoconstriction of the pulmonary artery, and vice versa is parasympathetic. Number 2 is chemical factors. We wanted to know the name of chemical substances causing vasoconstriction of pulmonary artery, like catecholamines, serotonin. This is very important. It increases the pulmonary vascular resistance. Vasodilator like acetylcholine, which is the main chemical transmitter of parasympathetic, and isoproterenol. Number 3, systemic hypoxia, and we say it today, which is oxygen tension effect on pulmonary vascular resistance. Number 4 is the respiratory movements. During inspiration, you know that the pressure in the thorax is going to be low, so pulmonary arterial pressure is going to be low. Resistance is going to be decreased, while during expiration the reverse occur. So number 4 is going to be respiratory movements. It's very important. You should know it by heart. Lung diseases. You know, when we study before emphysema, I said to you that there is going to be narrowing of pulmonary arterioles. Emphysema is one of this. Pulmonary fibrosis and also pulmonary embolism. So you are going to have many lung diseases which can increase the pulmonary resistance, and this will affect the heart. Doctor, why you say this? If pulmonary artery is going to be constricted, it will represent resistance to the right ventricle pumping, and this seems to be logic. Right ventricle pumps the blood to the pulmonary artery. So if the right ventricle faces an afterload, afterload means resistance. So it will be reflected on the right ventricle ability to pump. At the end, right ventricle is going to fail. And this means that lung diseases have reflection on the heart, on the right ventricle, resulting in right ventricular failure. And this is called core pulmonale. Core, what do you mean by core? I mean heart. Pulmonale means lung. So when I were a student, I make this. I put an arrow from pulmonale to core, which means that second word is going to be reflected on the first one. Lung diseases, pulmonale, is going to be reflected on the core, which you mean by it the heart. This is very important to understand today. And I told you that pulmonary pressure is going to exceed 30 millimeter mercury. What about left atrial pressure? Suppose that you have here the mitral valve. This is the mitral valve, which is the valve between the left atrium and the left ventricle. This valve is narrow, so left atrial pressure is going to increase and pulmonary venous pressure is going to increase. It will not accommodate the blood coming from the lung, so blood will be stagnant in the pulmonary capillaries, which resulting in high filtration pressure, because in capillaries it have a thin wall. It cannot tolerate the high pressure on the wall of pulmonary capillaries, which is going to result into pulmonary edema. So this is the condition. The alveoli is going to be filled with blood. Doctor, why? Because if the pulmonary capillary, as I point with my finger, is full with blood like this, full with blood, so there will be filtration into the center of the alveoli, represented by this black arrow, resulting in this condition. So this condition is going to be the end result, which I am pointing at. This results in difficulty to breathe. The patient cannot sleep flat. He should elevate the pillows behind him as if he is semi-sitting position. He's going to have difficulty in breathing, and this is called orthopnea. You know that ortho means position and pnea means breathing. So you have difficulty now to breathe. This is very important. What about cardiac output? Is the third factor affecting the pulmonary arterial pressure. From previous cardiac videos, during heavy exercise, cardiac output increases about 7 times. However, this leads only to a small rise in pulmonary arterial pressure. Doctor, why? Because there is a great ability to distend. You know that pulmonary circulation is characterized by distensibility. This occurs by distension of pulmonary capillaries, by increase the number of open pulmonary capillaries. As I said to you, we have some pulmonary capillaries are opened while others are closed. You need to reopen the closed pulmonary capillaries according to the effect of exercise, as well as the rate of blood flow through them. Red cell takes 0.75, which is 3/4 second, to traverse a pulmonary capillary during rest, while it needs 0.3 seconds during exercise. We are going to move now to the factors or dynamics of fluid exchange in pulmonary capillaries. How the interstitial fluid is formed in the lung tissues. This is according to a German scientist called Starling. Starling put forces, which is balance created by God, forces that favor the fluid filtration across the pulmonary capillaries, represented by these black arrows. We have three forces pushing fluid from pulmonary capillaries to pulmonary tissues. Number one is pulmonary capillary pressure, 7 millimeter mercury. Second one is plasma proteins present in the lung tissues. Plasma proteins, it have high osmotic pressure. It will attract the water towards it. These plasma proteins, which is called interstitial fluid osmotic pressure, because the proteins are present between the tissue spaces. The force equal 14. So you are moving the fluid from pulmonary capillaries to the tissues by the effect of plasma proteins in the lung tissue. Till now you have two forces, 7, which is pulmonary capillary pressure, 14, plasma protein or interstitial fluid colloid osmotic pressure. If you add these two forces, equal 21 millimeter mercury. Another force, you know that the tissue has got spaces. There is spaces between the lung tissue, which I put my finger on it. You have negative pressure here. Negative pressure, I means by a negative pressure, it is less than the atmospheric pressure. And every time we symbol to the atmospheric pressure by 0 millimeter mercury. The negative pressure is less than the atmospheric pressure by 8. Negative 8 millimeter mercury. And all of you know that atmospheric pressure is 760 millimeter mercury. This is the standard pressure which we are going to compare regarding it. So I want you to calculate the filtering force. You will say 7 plus 14. Negative 8? No, it will be plus 8. If you are going to add by positive values. You know that it is negative related to atmospheric pressure. But if you count, please calculate it in a positive value. So filtering force will be 7 plus 14 plus 8, which is equal 29 millimeter mercury. Yes, 29 filtering force. What about the opposite force? The opposite force is present at the wall of the pulmonary capillary pressure. Opposite force is this, which I am going to make it in the black circle. These are plasma proteins, which is the guard, and it guards the opening of pulmonary capillary pressure present at the wall. It has high molecular weight, so it is present here as if an obese one squeezed along the narrow wall. This black circle represents the plasma colloid osmotic pressure. So you have two colloid pressure. One plasma protein present at the wall of pulmonary capillary, and it push the water moving outside the capillary to tissues back to capillary. It will suck it. It will pull it upward, and the force equal 28 millimeter mercury. 28, I mean plasma colloid osmotic pressure. So you have two plasma protein, one present at the tissue, moves the fluid from capillary to tissue by force equal 14 millimeter mercury, and the opposite or antagonistic force which pull the water from the tissue to pulmonary capillary 28. So I want you to imagine you have three filtering forces equal 29 millimeter mercury and antagonistic force, which is called reabsorbing force, equal 28 millimeter mercury. So the difference will be net filtration pressure equal 1 millimeter mercury. So this low filtration pressure, it accounts for alveoli is almost dry. This is very important. And also you have another cause. Lung is characterized by high lymphatic drainage, which I am going to discuss later on in capillary circulation. Lymphatic capillaries has the ability to move excess fluid in the lung and return it back to systemic circulation. This is very important, and I want you to know that lymph, I mean by the word lymph, interstitial fluid. So I don't want you to be disturbed or confused. The negative pressure between the tissue spaces, it can suck out excess alveolar fluid through the opening between alveolar epithelial spaces. So what about pulmonary edema? Pulmonary edema means accumulation of fluid here in the lung tissues or between tissue spaces. Accumulation at first means high filtration forces, while low absorption forces. So if you have rise of pulmonary capillary pressure, it will be because of what? You will say here, mitral stenosis or left ventricular failure, as Dr. Yu described before. Also, damage of pulmonary capillary membrane. Why? There is excess leakage of fluid across the pulmonary capillary wall. So you are subjected to infections like pneumonia or inhalation of irritant gases like chlorine. This is very important. You should know. This is very important, and we will discuss later on. You have two factors which can pull water from pulmonary capillary to tissues. This is called lymphagogue. Gogue means lover, like philic. You have certain substance which attract water from capillary to the tissues, like histamine. Suppose lymphatic drainage are obliterated by thoracic tumor, so you don't have a drainage system, so fluid accumulates here between the tissue spaces. Or plasma proteins guarding the wall of pulmonary capillary, which is a reabsorbing force, is low. You have hypoproteinemia, and this decreases the plasma colloid absorbing osmotic pressure. But at the end of our video, I want you to know that God makes pulmonary edema safety factors. I want you to know this safety factor. Why? You have a certain margin of safety against edema. I will discuss it by numerical values. You know that pulmonary capillary pressure equal 7 millimeter mercury. This is one of the filtration force, while plasma colloid osmotic pressure responsible for absorbing equal 28. This means what? You have 21 millimeter mercury safety. I mean by this, pulmonary capillary pressure should rise above the difference between it and plasma colloid osmotic pressure, which is reabsorbing force, to make edema. So you have still 21 millimeter mercury, which is the difference between 28 and 7, safety factor against edema. Edema to occur, the pressure should rise to 30 or 35 millimeter capillary pressure, millimeter mercury pressure in chronic cases, because in these cases the lymph vessels expand greatly, which increase their ability to carry the fluid away from the interstitial spaces. So at the end of our video, we discuss functional characteristics of pulmonary circulation: distensible, low pressure, high compliance, high flow, rapid flow, venous return 1 to 2% above right ventricular output, effect of gravity, alveoli is kept dry, and we discuss the effect of excessive lymphatics, and also discuss the low filtration pressure, net filtration pressure, effect of hypoxia, local vasoconstriction, which is contrary to systemic vasodilatation, regulation of flow. Overall, we know that if cardiac output increases during exercise 7 times, the flow will increase slightly. This is very important. Regional regulation, effect of oxygen tension and gravity. As you know, the difference between the pulmonary arterial pressure at the apex and at the base. Factors affecting pulmonary pressure. We said that pressure in pulmonary artery 25/10, mean pulmonary pressure 15 millimeter mercury, pulmonary capillary pressure 7 millimeter mercury, pulmonary venous pressure 1 to 5 millimeter mercury. Factors affecting pulmonary pressure: resistance regarding nervous, chemical, oxygen tension, respiration, and lung diseases. And we said that in lung diseases, pulmonary arterial pressure exceed 30 millimeter mercury, like emphysema, pulmonary fibrosis, pulmonary edema, which is going to be reflected on the heart, called cor pulmonale. Pulmonale means pulmonary or lung disease. Pulmonary arterial vasoconstriction will result into right ventricular failure, and this terminology is very important for medical students. We discuss if left atrial pressure increases, pulmonary venous pressure increases, pulmonary capillary pressure increases, and excess fluid is going to enter into the center of the alveoli, which makes pulmonary edema. And the cardiac output, we discuss its effect on pulmonary arterial pressure, and the pulmonary circulation is high distensible circulation, so flow is not going to increase markedly and resistance decreases. Regarding the dynamics of fluid across pulmonary capillary, Starling, who is a German scientist, told us there are 3 filtering forces: pulmonary capillary pressure 7 millimeter mercury, plasma protein colloid interstitial osmotic pressure 14 millimeter mercury, and also negative pressure between tissue spaces, negative 8 millimeter mercury. If you calculate filtering force, add 7 plus 14 plus a positive value of 8 equal 29 millimeter mercury, while the reabsorbing force is only plasma colloid osmotic pressure, represented by the black circle, 28 millimeter mercury. So the net filtration force 29 minus 28, 1 millimeter mercury. Low net filtration pressure is one of the factors which keep alveoli dry, beside excessive lymphatic drainage and the negative interstitial fluid pressure, which sucks out the excess alveolar fluid through the openings between alveolar epithelial spaces. And we say that we have safety factor against edema 28 minus 7. Pulmonary capillary pressure should rise 21 millimeter mercury to be above 28 millimeter mercury, which is an only absorbing force to make high filtration pressure and edema. But in chronic cases, the pressure should increase 30 to 35 millimeter mercury, because in these cases lymph vessels expand greatly, which increase their ability to carry the fluid away from interstitial space. At the end of the video, I hope all of you get the benefit from our topic today, pulmonary circulation, and this was given by Dr. Mohamed Fayez, lecturer Physiology, Ain Shams University, Egypt. I hope good luck for you all.